My name is Vlado Perkovic. I'm a Professor of Medicine and Provost at the University of New South Wales in Sydney in Australia, and I'm a nephrologist and clinical trialist. IgA nephropathy is certainly classified as a rare condition. It's not diagnosed very frequently, but actually is probably much more common than we have anticipated to date, partly because until recently we've had no treatments available that really modify the course of the disease. And that's meant that clinicians haven't felt an urgency to diagnose it because it's not going to change really how they manage people. But it's also meant that we've underestimated just how progressive and how serious a condition it is for people who are affected. We now know from a number of studies across a range of different countries that most people diagnosed with IgA nephropathy run the risk of developing kidney failure in their lifetime, partly because it affects people in their youth, in the peak of their lives, 20s, 30s, 40s is the most common period where it's diagnosed. But also it's a lifelong chronic condition. And until recently, most of the studies had looked at a relatively short period of time and therefore underestimated, I think, just how high risk people with IgA nephropathy are for developing kidney failure. We now understand that clearly, and that's really redoubled our resolve to find better treatments to protect these people and make sure they can continue having the wonderful, productive lives that they've had to date. I think it's shifting dramatically. We're seeing now options for specific treatments for conditions that didn't, exist even 2 or 3 years ago. I got asked to give a talk on IgA nephropathy a couple of years ago, and the organisers told me that the year prior they had been tossing up whether to do a debate about whether you should treat IgA nephropathy at all, because at that point in time we didn't have any treatments. And I was able to explain to them the amazing pipeline that's now developed, and that's generated huge enthusiasm in the field. Nephrologists, I think, have a close affinity to IgA nephropathy. It's one of those sort of pure kidney diseases that only nephrologists manage, as opposed to, for example, diabetes, which can affect the kidney, but there are so many other specialties involved. So we've always focused in on the condition, but until recently had not had really very much at all in the way of specific treatments to help our patients. That's right. We've learned a lot also over the last couple of decades about how it develops. We now know that there are some people who, when they have some immune stimulant in their mucosa, say their nose or in their gut, causes the production of an abnormal IgA, a galactose-deficient IgA, and the body recognizes that and produces antibodies to that galactose-deficient IgA. They form immune complexes in the blood, which are filtered out by the kidneys, because that's the job of the kidneys, of course, but they deposit in the mesangium, in the glomeruli, and set up a local inflammatory reaction, and that progressively over time leads to kidney damage and kidney failure. Well, to use a simple term, it's the function of the fact that they're filters. That's their job. They're there to filter stuff out of our blood, and one of the things that they filter is the immune complexes, but they get stuck in the kidney, if you like, because of their size and various other factors, and then set up that local immune reaction, which causes that damage, that inflammatory process. We get glomerulosclerosis, we get tubulointerstitial fibrosis and sclerosis, and eventually the glomeruli drop out, and we see kidney function decline until kidney failure develops. But that process in most patients takes 10 or 20 years. So it's a slow process in the vast majority of patients, which has, I think, made it more challenging because it's taken us a while to recognize just how high risk these people are. But it's wonderful at the same time because it gives us real opportunities to intervene and change the trajectory of the condition and people's lives. Sibeprenlimab is an A-PRIL inhibitor. That's a drug that blocks A-PRIL, which is how the dendritic cells in the gut signal to B cells and plasma cells that there's a problem and that they should proliferate, they should differentiate and start producing lots of IgA. And it's part of the innate immune response in the gut. But when that IgA is abnormal, as it is in IgA nephropathy, these autoantibodies are formed and the other processes we've already spoken about take place. The beauty of APRIL inhibitors is that they inhibit the disease at its source. We're turning off the disease at the tap, if you like, by reducing the production of those abnormal antibodies, which means that they don't get into the circulation, they don't form immune complexes, and we've seen significant reductions in galactose-deficient IgA with these drugs, about 2/3. We see a reduction in immune complex formation. And what we've now seen over the last 12 months or so, and culminating today, is that this translates into benefits for the kidney. Last year, we reported the interim analysis data. This trial is a 2-year trial, but we pre-specified that we'd look at the effects on proteinuria at 9 months, and that if the drug reduced proteinuria by a significant amount, which we'd hoped would be 25 or 30%, that the drug could be approved on an interim basis by the FDA. Well, it turns out that at 9 months, the drug reduced proteinuria by 51%, an almost unprecedented amount for any treatment in any kidney disease. And so the drug has, of course, been approved in the US by the FDA on an accelerated basis for use in IgA nephropathy, but that was always dependent on those benefits being confirmed by effects on kidney function itself, on eGFR. So today, for the first time, we presented the eGFR data from the visionary trial from the time of that interim analysis, the first 320 patients at 12 months. And this is the first agent in the class and the first of the B-cell therapies there are a number in development, but the first of them to report kidney function data from a phase 3 trial. So it was a really big deal. And, we were sort of excited about what that might show. And what we found was that we recruited a high-risk group to the population. The placebo arm lost kidney function on average at a rate of 7.6 mils per minute per year, which means, starting off with an eGFR of 60, these people were perhaps 6 or 7 years away from needing dialysis. That's how rapidly progressive the condition was in these people. Average age of 39. In the Sibeprenlimab arm, that was reduced from 7.6 to 3 mils per minute per year. So reduced by more than half, almost 2/3. An extraordinary finding and a bigger reduction than any treatment we've seen in IgA nephropathy to date in any phase 3 trial, and one of the biggest treatment effects that we have for any kidney disease. And indeed, when we looked at the specifics, in eGFR slopes, a mathematical calculation that takes into account various factors, but when we looked at kidney function itself, in the placebo arm, people lost 4.8 mils per minute in total on average by 12 months, whereas in the Sibeprenlimab treated patients, they actually didn't lose any kidney function at all. The drug at 12 months appears to stabilize kidney function almost completely. Now, I'd expect these people will continue to lose some kidney function, but the data are profoundly impressive in terms of the magnitude of that benefit and the likelihood that this drug will ultimately preserve people's kidneys and keep them off dialysis, perhaps for life. That's an interesting question. And we've frankly never been able to even mouth those words before because it seems so unrealistic and science fiction-like. But if we're reducing the immunoglobulins, the production of the immunoglobulins, and therefore their deposition in the kidney, what we don't know is how efficient the kidneys are at getting rid of some of that IgA. So it could be that we see some of that IgA disappearing over time. I think it's speculation. We don't know whether that's true. And it'll be really interesting to see over coming years as more data comes out from histological studies and other analyses as to whether, in fact, that might be the case. But regardless of whether it does or not, anything that produces the magnitude of eGFR stabilization that we've seen in this trial is an incredible breakthrough for people with IgA nephropathy. So the only other thing that's probably worth talking about is safety. Given these drugs are immunomodulatory drugs, they are reducing immunoglobulin levels, both IgA but also IgG and IgM levels. One of the key outstanding questions is whether they are safe, whether they might increase the risk of infections or other abnormal outcomes related to immunomodulation. And the other exciting thing is we haven't seen any evidence of that to date. The data that's available so far looks incredibly clean. There's no increase in the risk of infections, no increase in the risk of serious infections, no deaths. It's very promising. But of course, the long-term data are going to be really important. And until we've got that we can't say with certainty that these drugs are safe, but it looks very promising so far.